Hello, everyone. I'm Dr. Carmen Puliafito, and I'm pleased to welcome back to Retina Synthesis Dr. Arshad Khanani. Arshad, welcome.
Great to be here, Carmen.
Arshad is a leading clinical investigator in the retinal pharmacotherapy space. He practices at Sierra Eye Associates in Reno, Nevada, and is associate clinical professor at the University of Nevada in Reno. And he's been a very busy man on multiple clinical trials, not the least of which is GATHER1 and GATHER2. So let's discuss GATHER1 and GATHER2.
Absolutely, Carmen. It's a pleasure to be here again and discuss with you the exciting data from the GATHER1 and GATHER2 studies. As you know, both studies are looking at Avacincaptad Pegol in treatment for geographic atrophy. Looking at GATHER1, it was a phase 2/3 trial, it's randomized prospective study looking at efficacy and safety of Avacincaptad Pegol. And in that trial, Avacincaptad Pegol was looked at with different doses, 1 milligram, 2 milligram compared to sham. That was the part 1. And patients were dosed 1 to 1 to 1. And then in part 2, Avacincaptad Pegol 2 milligram, 4 milligram, and sham were looked at. And in that part, they were randomized 1 to 2 to 2. And the study stayed masked throughout both parts until the primary analysis, which was month 12. And in GATHER2, is a phase 3 study, and we recently presented the data at AAO for the first time. And again, multi-center prospective randomized study. In GATHER2, we had 448 patients, and patients were randomized to either monthly Avacincaptad Pegol 2 milligram compared to sham monthly, and the primary analysis was at month 12. I think, Carmen, when you look at geographic atrophy, obviously, when you look at trials, you need to see what are the inclusion/exclusion criteria for these trials. And I think there are a couple of differences when you look at how the GATHER program was designed compared to traditional geographic atrophy trials. I think the key ones to highlight are that patients that were recruited for this trial were supposed to have GA, but not center point involving. So they can have pretty large GA, and they can have GA very close to the center, but it had to be non-center point involving based on multimodal imaging. And, this was obviously evaluated by the Duke Reading Center. And the other one was the GA in part has to be within 1,500 microns from the center of the fovea. So just kind of to keep in mind that that's slight difference compared to some other programs. So I think the bottom line, Carmen, is that both study met the pre-specified primary endpoint of efficacy in patients treated with Avacincaptad Pegol compared to sham. And I think this is really exciting because this is the first program to have 2 positive pivotal studies that met the pre-specified primary endpoint.
So can we talk just a little bit about the molecule itself? What does it do?
So the molecule is a pegylated RNA aptamer, and is designed to be a specific inhibitor of complement C5. So we know that there is enough preclinical evidence that, overactive complement system is being implicated in patients with geographic atrophy. So of course, that the disease is age-related, there's genetics, there's social, things like smoking, diet, and then of course the overactive complement system. And of course, we know that, complement system is quite complicated. You have the classical, the alternative, the lectin pathways, but they all come together. And then, as a field, we are targeting C1q, C3, C5. So Avacincaptad Pegol targets C5. And I think the key is that inhibition of C5 slows inflammation and cell death. So, we know that that's associated with development of GA. So it's a downstream target. And the one thing it does is that by C5 inhibition, we are potentially preserving the anti-inflammatory properties of C3a, which is more upstream. So I think the bottom line is that we are going after the complement pathway like many other programs, but we are more downstream, and we are trying to preserve the anti-inflammatory effect, because that can play out in terms of safety of this molecule also compared to others.
So what were the area reduction percentages in both studies?
So I think when you look at the reduction, you have to keep in mind, obviously, what we are looking at in terms of primary endpoint. You know, some trials look at observed data, some trials look at slope analysis. So, you know, I'll present to you some of the numbers. So obviously, both trial met the pre-specified primary endpoint. So in GATHER1, the pre-specified primary endpoint, there was 27.4% reduction in patients treated with Avacincaptad Pegol, 2 milligram compared to sham. In GATHER2, the reduction was 14.3% in patients treated with Avacincaptad Pegol compared to sham. So that's the data, you know, for the primary endpoint. Now, we also look at, you know, the growth, the observed data. And when you look at the observed data, those numbers are, you know, 35.4% in GATHER1 and 17.7% in GATHER2. So both trials met the primary endpoint, but there are differences. And I'm sure you're going to ask me why, because we know that GA is a very variable disease, the size, the location, and also, you know, the patient population. So there are some differences in the baseline characteristics. You know, most of the GATHER1 patients were in the US, most of the GATHER2 were outside US, but I don't think that matters. I think what matters is you have variable population in trials and you can end up with different efficacy numbers. But I think the bottom line is that if you meet the primary endpoint, then of course that shows that the effect is real. And that's what happened in this program where GATHER1 and GATHER2, both trials met the pre-specified primary endpoint.
So in GATHER2, the drug was administered monthly or bi-monthly?
Monthly. So in the first year, we are treating the patients monthly. So this data is from monthly, and it was also delivered monthly in GATHER1. But in the second year of GATHER2, it's a 2-year study, and then we also have an extension study after that. So in the second year, the patients who are treated with monthly Avacincaptad Pegol in the first year are re-randomized to receive either monthly or every other month Avacincaptad Pegol to see if we can keep that effect, continue the effect without decreasing, you know, and decrease the treatment burden by giving injections every other month. One thing I want to highlight, Carmen, is the fact that in both trials, we have seen an effect in the treatment group early, and that effect improves or increases over time. So basically, it's a compounding effect. The longer you treat, the more separation you get from patients who are untreated. So I think we know that GA is a very long-term disease. Some 65-year-old patient shows up with GA, they're going to live, you know, another 15, 20, 30 years. So the idea is that we intervene early and we continue treatment so that we can get the benefit. So the longer you treat, the more benefit you get. That's what we have observed. So we'll see what the second year data shows, whether every other month will also continue to show us the same treatment effect that we have seen with monthly.
When would the 2-year data be reported?
So, you know, we reported the first year data at AAO, you know, this year. So I would expect that, you know, a year from that. So hopefully we'll be able to report it by AAO of next year. I mean, it would just make sense that 12 months, 1 year, and then 24 months, second year.
So they've selected the optimal dose to be 2 milligrams?
Oh, yeah. The optimal dose is 2 milligrams. Remember, the GATHER1 was phase 2/3. So we looked at 1 milligram, 2 milligram, and 4 milligram. So we saw good efficacy with 2 milligram and 4 milligrams, but there was a higher rate, you know, of CNV with 4 milligrams. So 2 milligram is the dose. That's what was taken to GATHER2, and that's the dose that's going to be, you know, approved. As you know, they've already, you know, said that they have started the filing for approval with the FDA, which is great news for patients.
So let's talk about safety. What about inflammation, vasculitis?
Yeah,
other
so I
patients?
think, no, absolutely, Carmen. I think safety is super important, right? For a new drug. Obviously, we want to make sure there is no safety signals, there's no irreversible vision loss. And remember, these are patients that are going to have continuous decrease in their vision with GA progression. We are helping them slow it down. But at the same time, we don't want to have events that can, cause acute vision loss in these patients. So I think what we have seen in the complement inhibition program is obviously CNV. So, we have seen that in other programs. Here, we also saw that patients who were treated with Avacincaptad Pegol had higher rates of CNV compared to sham. So in GATHER2, it was 6.7% in the treated group compared to 4.1% in the sham group. And in GATHER1, it was 9% in the treated group compared to 2.7% in the sham group. So what we learned from, GATHER1 was that, in GATHER1, if you had a CNV, we stopped treating with Avacincaptad Pegol, but patients were monitored. And then we found out that this is something we have to watch. So there's an extensive CNV surveillance program that was implemented in GATHER2 study, where the reading center was involved very closely to help investigators confirm that this is CNV. And also they were looking at imaging at month 12 for all patients to rule out any CNV. So yes, there's a higher rate of CNV, but I think that's across the board for complement inhibition, at least for now. But I think the most important thing is that in GATHER2, there were 0 cases of IOI. There was 0 cases of endophthalmitis. There's no ischemic optic neuropathy. There's no vasculitis. So the drug appears to be very, very safe in terms of IOI or IOI related events. So I think this is really good because, again, these patients are not going to see improvement in their vision. They're actually going to see slow decline, but we are slowing the decline of the vision. So we need to make sure we have a very, very safe drug. And it's impressive to see how the safety looks for Avacincaptad Pegol in the clinical trial program.
What were the CNV percentages, sham versus treatment in GATHER2?
Yeah, so I just told you that it was 6.7% at month 12 in the treated group compared to 4.1% in the sham group. And in GATHER1, it was 9% in the treated group and 2.7% in the sham group.
Mm-hmm. But in GATHER1, we're also including the 4 milligram cases, correct?
No. This is the data for the 2 milligram.
Just for the 2 milligrams. There was an effort at looking at the different types of exudation that were observed in the GATHER2 trial. Can you comment about that study?
Yes, absolutely. I think, it was a post-hoc analysis, and actually they did it for GATHER2 as well as for GATHER1. And it was done by the Cole Reading Center at the Cleveland Clinic. And I think they looked at the total CNV percent. So I told you the total percent. Then they wanted to look at exudative MNV. And then they looked at non-exudative MNV. And then they looked at peripapillary MNV. I think this idea is that, we need to see what type of, exudation we are seeing. So this was done to see if, there's one type versus other. And, exudative MNV is MNV that, presents with new onset of fluid in either the subretinal space or intraretinal space. That was the definition. Non-exudative MNV is MNV that does not present with the new onset fluid in the subretinal or intraretinal space. In some cases, fluid may be presented in the sub-RPE space, and a case is considered to be, non-exudative MNV when the MNV may not be visible, but both a double layer sign and sub-RPE fluid are present. Because I think what we are looking at is, are there patients who already have non-exudative MNV that were part of the trial that either stayed the same or got worse over time and became exudative? And then, of course, peripapillary neovascularization. We all know what that is. So I think they were just trying to break it down to look at specific components. And I think that's because other programs have done it too. But I think the overall, conclusion is that yes, with complement inhibition, we have higher rate of CNV compared to untreated patients. But at the same time, we are seeing this, slowdown of geographic atrophy and this better efficacy or continuous efficacy or improving efficacy with continuous treatment. So I think it's something we need to discuss as clinicians with our patients, the risk-benefit profile, and what kind of patients are going to be ideal candidates for this.
Of course, these studies were done before angiographic OCT, which would probably show quiescent neovascularization in many, many of these eyes. And so what are the speculation about why anti-complement therapy leads to activation of CNV?
I think you asked the $1 million question here, Carmen, and you're a pioneer in OCT. So you would know, these answers about, what to look for before and during. And I agree with OCTA comment too, that I think I do OCTA on my patients where I'm suspecting non-exudative MNV. I think the bottom line is it a response to slow down of GA? Is the body's way to kind of slow down the GA progression? Is that why we are seeing this or not? There are a lot of hypotheses, but we don't really know the answer. But we do know that, this is something that we see even when you inhibit complement system to a level where you're actually seeing efficacy in terms of slowing down disease.
And the macular neovascularization was not vision threatening.
Well, I think, because patients are in clinical trials, right? They get caught early. So I think something to keep in mind is that we are not undermining this CNV, risk in these patients with complement inhibition. But I think patients need to be monitored closely. I mean, in trials, patients come in every month to be evaluated. So it's much easier to catch these lesions early, as as a clinician, that the earlier you treat, the better outcomes you have. So I think, that's something to keep in mind. Once, Avacincaptad, Pegol is available commercially, we need to make sure that patients who are being treated, we are looking, for CNV. I won't do FAF to measure GA lesions every month when I'm treating these patients, but I'll definitely do OCT just to make sure that we are not missing any early onset exudation.
Well, this has been a great discussion, and we look forward to following through with this next year or even sooner.
Always a pleasure to speak with you, Carmen. It's really exciting times. I mean, this is a big unmet need with no treatment for these patients. We see these patients go blind in front of our eyes. 10 years ago, they'll have 20/20, and 10 years later, they'll be legally blind. So having Avacincaptad Pegol, the first treatment to meet pre-specified primary endpoint in 2 pivotal trials is very exciting. And hopefully we have approval for this agent in the near future so we can help our patients with GA.
Great. Exciting. Thank you.
Thank you.